Hello, everybody, and a warm welcome to this Barts afternoon on dementia and delirium. It's really wonderful to be here as a relative newcomer to Queen Mary University London and to ELFT. It's lovely to be sharing this afternoon with good colleagues from across East London, Barts and Queen Mary, talking about the topic that we all work in every day. And I'm also delighted to say that to give a few words of introduction, we're joined by the director of the Wolfson Institute of Population Health, Professor Fiona Walter.
So, thank you very much, Claudia. Can everyone hear all right up there? Yeah, good. Well, a very warm welcome to everyone. It's a fantastic turnout today and a great pleasure to be asked to introduce this afternoon. I'd like to start by introducing myself. I'm Fiona Walter, as Claudia says, Director of the Wolfson Institute. I'm also a GP and Professor of Primary Care Cancer Research, which means that I am absolutely ignorant about what you're going to be talking about this afternoon. And I wish I could stay all afternoon to hear and be educated, but it's a fantastic program you've got ahead of you. So I wanted to say a few words about the Wolfson Institute of Population Health, because some of you may not be completely familiar with it yet. The first thing to say is that we're spread out over quite a few locations. On the left, you can see that is the Yvonne Carter Building in Whitechapel. In the middle is our Newham place, and on the right, Charterhouse Square. We're actually spread out over 11 different locations. So one of the longer term hopes and aspirations is to bring us all together under one roof. So we launched on the 1st of August in 2021, and the launch was a merger of the Wolfson Institute of Preventive Medicine and the Institute of Population Health Sciences. And by bringing them together, we formed the Wolfson Institute of Population Health. We're an interdisciplinary collaboration, and our research is focusing on improving population health and reducing health inequalities. So we have 5 centres in our institute, and you'll see in the middle the Centre of Psychiatry and Mental Health represented today. But we also have a Centre of Primary Care, a Centre of Evaluation and Methods, which has 2 trials units, the Centre for Public Health and Policy, and the Centre for Prevention, Detection and Diagnosis, one of whose units is the Preventive Neurology Unit, very well represented by Charlie Marshall here today, who will be talking to you later. And together we have, in fact, nearer 400 staff now from when this slide was put together. And we have over 90 doctoral students. So just to give you a sense of the size of what we're trying to do. We've also got 3 cross-cutting themes. We've got one focusing on complexity, behavioral, and social science, one on health data science, and one really focusing on developing a cross-institutional public advisory panel. And these 3 cross-cutting themes are key to the development and delivery of the sort of research that we are trying to do. So you can see that together we have a real breadth of academic expertise, not only what you can see there, but we have epidemiologists, we have people who focus on economic evaluation, we have people who do qualitative work as well as quantitative work, and together we form a bedrock of groups who can collaborate freely across all our centres. But it also enables us to collaborate across the Faculty for Medicine and Dentistry and across the whole of QMUL and indeed the wider local context. So this is just a brief summary of the income from bids that was awarded last year. And you'll see that we have a number of major bids of over 1 million that we were successful with, and that most of our funding comes from the government, mainly from the NHR and MRC, but also a substantial amount from charity and some from commercial and other funders. And our larger awards include things like the NIHR School for Primary Care Research, which is set between 9 universities, and we were a new member when we joined about a year and a half ago. For another illustrative grant is that from the Wellcome Trust, which funds the PhD program for primary care clinicians. We had a substantial funding last year from the Barts charity for the ACT, the Advancing Clinical Trials, and then other charitable funding, such as the one I got, which started at the beginning of this year, which is around advancing detection of cancer. So I just wanted to draw you to some of our larger global awards as well, particularly the one awarded to Vicky Bird. Is Vicky here today? Oh, she's not back. Okay. And she's probably working on this major grant that she received, which is for community management of long-term conditions in South America. So we also not only do this sort of cutting edge research, but we also deliver a great deal of education, both to undergraduates, but also postgraduate talks. And I thought you might be interested in this list I was sent just yesterday about the range of both postgraduate teaching and distance learning courses that we deliver. And you'll see from mental health, we deliver such a range: creative arts and mental health, cultural psychology and psychiatry, psychological therapies, cultural psychology and psychiatry, etc., etc. So really a range that we're very proud of delivering. So focusing down on our Centre for Psychiatry and Mental Health, aptly led by Claudia Cooper, who's chairing today with Vicky Bird. We have our 3 units, one for psychological medicine, one for social and community psychiatry, based out at Newham, and then our youth resilience research unit. And we're really proud of the partnerships that we're growing and developing across ELFT, across the Barts community, across North East London, and across the whole of the UK. And our vision is that of increasing collaborations with our academic and clinical partners across North East London. And I'm sure that's what you'll be doing today, sharing and discussing the sorts of research that's being presented today. But I hope also having enough time to be able to have good conversations and develop new collaborations with this overall vision of producing new research to provide more equitable and better care for all older people in East London. So with that, I bid you a really productive afternoon and say, who am I handing over to? Is it to Claudia next? To Charlie next. Thank you very much.
Thanks, Fiona. So, hi everyone. My name's Charlie Marshall. I'm a neurology consultant at Barts Health and at ELFT, where I work in the memory clinic with Nick, Claudia. And I'm also a dementia researcher here at Queen Mary, where I lead the dementia work in the preventive neurology unit, as Fiona said. And in this first session, we're going to be talking about newer and better ways that we might start to deliver more precise diagnoses of the diseases causing dementia in memory clinics. So I'm gonna start. There's a slight change to the order of the program. I'm going to go first, then Nick Bass is going to go after me. I'm going to talk about a vision for how we might start to get better at this using tools that I think we might be able to use throughout kind of memory clinic settings that don't require a kind of ivory tower environment to improve our diagnosis of dementia. And then Nick is going to talk specifically about how we can bring genetic testing into NHS memory clinics and what that might add. So I just start some declarations. These are people that I've had money from in one form or another before I go on. So dementia diagnosis is a really huge problem. So 2/3 of people with dementia have a diagnosis, a third are living with no diagnosis at all. And even the people that have a diagnosis have waited on average about 3 years to get one. And we know that diagnosis is not equitably distributed. So people who are more deprived, people from minoritized ethnic groups are diagnosed later and less accurately for a variety of reasons. Some of that is because of geographic variation in what services are available. Some of it is due to equitable access to secondary, tertiary services. Some of it is due to some of the diagnostic instruments that we have, like cognitive assessments that are not culturally fair. And as many of you, I'm sure, have seen in memory clinics, we use a lot of mild cognitive disorder diagnoses, which just means that we don't know really whether somebody's developing dementia or not. And this leaves people in limbo and means that they need to be followed up for a number of years to see whether they are in fact developing dementia. And dementia is different to other diseases because the diagnosis itself, without access to any disease modifying treatment, can have a huge benefit in terms of long-term requirements for care. Because having a diagnosis means that you access effective counselling, advice on planning for the future. And we know that that tends to lead to people having better health-related quality of life, staying in their own home for longer. So just improving access to early diagnosis of dementia in the current environment could save hundreds of millions a year across the NHS through reduction in those long-term care costs. But of course, disease-modifying treatments for dementia are on the horizon, and they're really going to light a fire under how much better we need to get at diagnosing accurately the biological process that's causing somebody's dementia so they can have access to these treatments. And the scale of kind of societal importance of providing access to those treatments could be huge. So even a sort of modestly effective disease-modifying therapy that slowed the course of Alzheimer's disease by 2 or 3 years could save the UK economy over 12 billion a year. So it's a huge kind of potential to be gained from improving our ability to diagnose dementia. So here's an example of a patient that comes to the memory clinic. It's a scenario that you all will have seen very commonly. They're worried about their memory. They're forgetting things. They left the tap on. They've had an MMSE. It's 27 out of 30. They've had a scan. It has one of these unhelpful reports. It says age-related involutional change with mild to moderate small vessel disease. There's nothing particularly unusual or complex about them, and there's a very long neuropsychology waiting list, so they're not suitable to be referred to the neuropsychologist. There's no lumbar puncture service available. There's no amyloid PET available. So there's no other diagnostic modality available to them. And the only thing that can be said about this patient is that they have mild cognitive disorder. They may or may not be developing Alzheimer's disease. There's no other way of being sure. And all you can do is see them again in a year and maybe again in a year after that. And actually, in most services, the follow-up isn't commissioned. So we have a system in the memory clinic where we keep a sort of paper record of people that we want to contact and invite back in a year's time because we can't leave them open to us. This isn't commissioned. So this is the sort of fairly common scenario for the standard of diagnosis that we're offering people in memory clinics. So by contrast, if you go to your doctor with a breast lump and get referred to the breast clinic, you have this array of diagnostic modalities. You have ultrasound, CT, possibly MRI. You have pathological diagnosis with tissue characteristics, with kind of an exact kind of molecular characterization of your tumor. You have an MDT discussion of results, and you end up with a diagnosis like this one: left triple negative invasive ductal carcinoma, 49 millimeters in size, grade 3, and you've got scores for all the molecular characteristics: estrogen receptor, progesterone receptor, HER2. You've got your staging, your PT2, PN0, margins positive. If you're young, you also have your BRCA genetics sent so that you can have a precise genetic diagnosis and have your family counselled, and you end up with a personalised treatment plan, all within the space of a very small number of weeks. So the difference between what we're doing in services like cancer and what we're able to do in memory clinics is shocking. And we should all be sort of jumping up and down, demanding more precise biological characterization of the diseases that we're looking at. So I'm going to kind of present a vision for how I think we might transform this situation. And I'm going to slightly shamelessly use it as an advert for some of my own work, trying to develop some diagnostic technologies that I think we could be using in memory clinics. And I think the 3 things that we need are, we need reliable imaging metrics of neurodegenerative change so that we can say precisely what someone's scan is and isn't showing and not rely on those very unhelpful non-committal radiology reports like the one I've described. We need sensitive culture fair assays of cognitive change. We need to know that things are starting to go wrong in somebody's brain in a way that suggests they're developing a neurodegenerative process. And I think we need to move away from our kind of conventional pen and paper tests in order to find things that are going to be a really good sensitive marker of what's happening in your brain and be culturally fair. And we also need to think about how we can provide corroboration of molecular pathology in life. I was slightly disingenuous with the comparison with a breast clinic, simply because, of course, in the breast clinic, you have access to tissue pathology that we can't do with somebody's brain in life. But nevertheless, we should be really pushing to have whatever molecular characterization we can. So an example of this is the abated study that I'm leading, which began in June. And this stands for Automated Brain Image Analysis for Timely and Equitable Dementia Diagnosis, and it's funded by NIHR. So you can see in this video here, this is the same person's brain when they've been to the memory clinic and had a diagnosis of mild cognitive disorder and come back again in a year, and it's not clear they're any worse and they've still got a diagnosis of mild cognitive disorder. And both of these scans are reported as normal, but actually the brain is changing in size and shape in a way that you can see when you morph between the two. I'll just play that again. And so this kind of subtle change in size and shape, we can't really detect reliably with the human eye when we're looking at brain scans. But we think this is ideally suited to a computer vision solution because the changes are subtle and they occur in a particular kind of spatial distribution in something like Alzheimer's disease in a way that you could train an AI algorithm to be sensitive to. And so this is a partnership with a company called AI Gnostics. They're a medical deep learning company, and they've developed this convolutional neural network approach to interpreting structural brain scans that uses a patch-based sampling approach. So it takes little three-dimensional patches of the brain and feeds them through a classifier, and it produces a kind of heat map of probability of each region of the brain and how strongly it's signaling the risk that that person has Alzheimer's disease, like what you can see in the bottom panel there. And using kind of existing research data, this can very reliably differentiate healthy controls from people with Alzheimer's disease with 97% accuracy. But even in those people with mild cognitive disorder, it can differentiate who's going to go on to develop dementia over 2 years with 92% accuracy. So this is a huge improvement on what we're able to do clinically. But of course, this is a nice, well-phenotyped, clean research data set from the Alzheimer's Disease Neuroimaging Initiative. And actually, if this is ever going to work for us in the NHS, we need it to work with the kind of messy, noisy brain scans that people are having in memory clinics every day. And that's what our project is all about. The advantage of this technology is that it can be used with NHS scans. It has a harmonization procedure that means it can work across different scanner strengths and manufacturers. And it's kind of computationally, it's something that could be used on NHS hardware. And this is the sort of report that, this is a mock-up, this is the kind of report that we hope we'll be able to generate with this software. So the sort of headline is, this is somebody with mild cognitive impairment who's predicted to convert to dementia. The diagnostic confidence is 93%, the algorithm has, and there's an estimated conversion time. And then there are all these metrics for regions that are smaller than a matched control population, visualized on the brain, the kind of quantification and location of white matter hyperintensities. And so this could be loaded as a PDF onto PACS alongside the radiology report to give you a more precise idea of whether there is meaningful neurodegenerative change. And so we are recruiting people from inner East London boroughs, from ELFT memory clinics in Tower Hamlets and Newham, from NELFT memory clinics in Waltham Forest. And we've got two parts to this. So we are recruiting 200 people prospectively, so we can follow them up over 2 years to see if they develop dementia. We've also got confidentiality advisory group approval to go back through 20 years of records and scans and find historical cases that we can use as well. And so we're hoping that we'll end up with a really big set of scans and matched clinical data, where even if there's a huge drop-off in performance related compared to what we get in a nice, clean research data set, we can at least use this as a training data set to start developing an algorithm that can work in this sort of data. And importantly, because we're doing it in East London with all of its diversity, we can look at bias and whether the algorithm that we're developing is going to kind of mitigate or worsen the inequalities in access to a dementia diagnosis that we know about. So now I'm going to move on to another study that we've got starting next month, which is also NIHR funded. And that one's called Diadem. It's digital assessment of auditory perception in dementia. So we're really interested in this study in what somebody's ability to perceive sound tells us about what's happening in their brain and whether that could be a means of assessing cognitive change in the memory clinic. So this isn't about whether somebody's got wax in their ears and kind of can't hear something quiet. It's about processing complex sounds, being able to understand speech when it's degraded. So when you're in a busy restaurant and lots of people are talking around you and you're trying to listen to what one person is saying, it's very, very computationally intensive for your brain to do that. It's really placing a lot of demands on your neural machinery, and we take that for granted. And it's that type of hearing when there's noise in the background, when the speech signal is degraded and your brain is having to work really hard to fill in the gaps. And we think that that is a useful canary in the coal mine for when things are starting to go wrong in your brain. And so this is just an example. So if you listen to this sample of speech, anyone hear what that was? I'll play the clean version.
He plays in a jazz band every Monday night.
If I now go back, it's really easy to understand once you know what it is, but it's just an example of how the speech can be degraded and your brain can learn to interpret the degraded speech. So the reason that we're so interested in this is because, as I said, our brains are working so hard to interpret these sounds in everyday life. And because we know that dementia syndromes affect this type of hearing very early on. It's what our patients tell us in clinic. We see people all the time where the family say they don't seem to be able to hear what we're saying when we're all around the table having dinner, but we keep taking them to Boots to have their hearing checked and they say it's fine. And it's because it's not their pure tone audiometry that's the problem. It's not their ability to hear quiet sounds. It's their ability to interpret complex auditory environments. And we've done some work. If you look on this panel here, this is work we've done in UK Biobank. In UK Biobank, nearly 200,000 of the participants had a speech in noise hearing test at baseline. And this is how performance on that test predict the risk of dementia. And you can see that it's a very early warning sign. So that red line, which is the 20% of the population that are worst at the speech and noise hearing test, are getting dementia at a much greater rate, even 10 years out from the baseline test. We've also looked at these tests in healthy people compared to people with early Alzheimer's disease, and they distinguish the two very accurately. With more than 90% accuracy, they can differentiate the two. And we've got some evidence that they're very, very sensitive. So we can detect an improvement in performance on these tests after a single dose of donepezil in someone with Alzheimer's disease. So to give you a comparison, if you're taking donepezil regularly, it improves your mini mental state examination score by about ½ a point on average. It's a size of effect that's almost impossible for us to detect using those conventional pen and paper tools. But this type of test is a sufficiently sensitive assay of what's going on in your brain that we can detect that tiny little bit of improvement. And we've also shown in UK Biobank that performance on this type of test correlates with brain volume in the parietal and temporal lobes in a pattern that you can see here, which is really replicating the anatomy of Alzheimer's disease. So it's telling us that somebody's got atrophy in a pattern that they would get if they had Alzheimer's disease. So for all these reasons, we're really excited about these sort of hearing tests being a tool to improve early diagnosis and early measurement of a failing brain that we think you could use anywhere. So they're measuring clinically relevant changes. They're measuring those symptoms that people are struggling with communication in daily life. They're culturally fair because you can make the stimulus and the response task very, very simple. You could just make it a number and all they have to do is pick from a choice of two which number was being said. And the way that you make it more difficult is by degrading the stimulus more, making the sensory processing task harder, but not placing any extra demands on kind of education or language ability. They're also cheap and scalable. You can put these tests into a web app and they can be delivered anywhere with a computer terminal and internet connection. And so we're developing digital prototypes for use at scale and trying them out in memory clinics to see how much they help sort out who's got Alzheimer's disease and who's just depressed and not sleeping well. And again, doing it in these inner East London boroughs that we know are very diverse, so we can specifically evaluate the culture fairness and any possible biases in. So in year one, we're just kind of piloting the tests, refining exactly how we want them to work, putting them into a web app. as a battery. And then from year 2, we're recruiting anybody that sets foot in a memory clinic in East London is eligible. And then we're going to follow up patients with Alzheimer's disease and mild cognitive disorder longitudinally to establish how well we can kind of monitor change and predict disease trajectories using these tests. And we're combining them with blood biomarkers. So there's lots of interest in using blood biomarkers to improve dementia diagnosis. And there are various kind of candidates that have been looked at. This is quite a good sort of summary. So amyloid beta, for various reasons, is not easy to measure in blood and not nearly as useful in blood as it is in CSF. Total tau is quite non-specific and again problematic in blood. Phosphorylated tau forms like p-tau 181 is being widely used at the moment. There are others as well. Is looking the most promising. It's the one that everyone's really excited about. It seems to be very, very specific for Alzheimer's disease pathology and can be measured quite well in the blood. And then neurofilament light is quite a good measure that reflects the rate of neurodegeneration, but it's not specific of Alzheimer's disease. So any neurodegenerative disease puts your neurofilament up. But perhaps in combination, you could use phospho-tau forms as sort of proof that you've got Alzheimer's disease pathology in your brain, along with neurofilament light to reflect how kind of rapidly the neurodegeneration is occurring. The thing about these blood biomarkers is they're not good enough to use in isolation. So if you look at this curve here, the p-tau 181 is this upper line, which is doing the best, but even then the area under the curve is only 0.74. So it's not enough to be used on its own as a clinical test. And one of the reasons for that is that well, some people are getting non-Alzheimer's disease dementias, and so that's a potential problem that some people develop dementia for other reasons. But also because lots of people have a brain full of Alzheimer's disease pathology, amyloid and tau, but don't have any symptoms and will be hit by a bus in 10 years' time without ever having developed symptoms. And so the positive predictive value of these tests is always going to be a problem. And you can see in this graph on the right here, this is looking at amyloid in CSF and PET rather than tau. But these are people with mild cognitive impairments, people with memory concerns. And the people who are amyloid positive, over 5 years, only about a third of them actually develop dementia, even if they're amyloid positive. So the kind of positive predictive value from this is limited. So our thinking is that you need to combine these with something that is a proximity marker for dementia. So you need to know that somebody has Alzheimer's disease pathology in their brain, but also they've got some signs of a failing brain that suggests it's having a meaningful effect and they're going to be developing dementia soon. And we think that that combined approach is going to be the most informative. So our hope is that when this patient with subjective memory concerns comes to clinic, they do some online central auditory tests, and the auditory perceptual abnormalities suggest that they've got some early dysfunction of their temporal and parietal lobes. They've had an MRI and it's been fed through our AI algorithm, which shows that they've got a hippocampal Z score of -1.8, so they're getting quite low compared to an age-matched population. But also the algorithm's detecting a 93% likelihood that they'll progress to dementia. They've had a blood test that shows they do have a raised p-tau 181, so that's compatible with AD pathology. And then neurofilament lights up a bit as well, suggesting they've got an intermediate rate of progression of their disease, not at the super high range, but definitely some neurodegeneration happening. And if appropriate, they also get neurogenetics, not appropriate for everybody, but if it is appropriate, it's the sort of in vivo molecular diagnosis par excellence, and Nick's going to tell us more about that in a minute. And they then end up with a diagnosis which is much closer to what somebody's getting in the breast clinic. So we could say this person has early symptomatic hippocampal predominant Alzheimer's disease. They're positive for tau, positive for neurodegeneration. They've got an estimated time for dementia of 3 years, and then they can have a personalized treatment plan. Then they are eligible for a specific treatment for Alzheimer's disease. And when there are multiple treatments available, we might have different treatments that are more appropriate depending on your disease intensity, how long it's likely to be before you progress to dementia, etc. So this is where we hope to be in the years to come. Thank you. Any questions before I hand on to Nick? Yep. Can use it as a training task for people with Alzheimer's disease. Yeah, it's a good point. So some work that I've been involved with, led by my colleague Chris Hardy, who's also involved in our Diadem study, has shown that actually the kind of perceptual learning effect that you all experienced when you kind of went back and heard the degraded sound again, knowing what it said, that perceptual learning effect is actually preserved in Alzheimer's disease. And so it's interesting that using this, you can actually show what kind of residual capacity for learning there still is in somebody who's in the early stages of dementia. So we're quite interested in thinking how we extend that. Do we use it as a way of kind of developing communication strategies based on that learning? Do we use it as a method of brain training? Do we use the amount of residual capacity for perceptual learning as another kind of element of disease biomarker? Not sure exactly how it's most useful yet, but yeah, it's a really interesting property of these tests that you do improve during a session as you learn more and more. No, I take a very kind of pragmatic view to this recruitment. I think if you exclude anybody with hearing aids, you're excluding a massive chunk of memory clinic population, and then it becomes very difficult to use the test in the real world. So my approach is to say everyone can be in the study. We're going to do pure tone audiometry. We're going to record whether or not they're using hearing aids and see how they perform, and see when we analyze the results afterwards whether you needed to exclude those people or not. Yeah, I mean, we're gonna evaluate very carefully for all sources of bias, both due to gender, education, ethnicity, language spoken, socioeconomic status, everything you could think of. We're going to evaluate carefully as bias included. Yeah. All right, thanks everyone. I'll hand over to Nick Bass.
Thank you, Charlie, and afternoon, everyone. So I'm the other half of the Tower Hamlets Memory Clinic double act today. So rather than regurgitate the latest findings in the genetics of dementia, I'm going to talk about implementing genetics in the clinic. I think it's sort of an apt time to do that. So apologies to people who've been coming to the academic afternoon for years. This is my third go at this talk, so I hope I'm going to get it right this time. But I actually think I've got something helpful to say this time round. And so in the spirit of that, I'll go straight to the take-home message, which is the title of this slide, that psychiatrists can now directly order genomic testing for dementia. This is a slightly disingenuous slide because technically speaking, it was possible beforehand. But the actual reality was it's kind of impossible to organize. And that was because you had to look at each gene individually and also get the funding for this because it was locally commissioned. But things have changed. There's been a massive advance in genetic testing, in genetic technology, mainly sort of advances in sequencing technology, and this now allows a whole bunch of genes, 30 genes, to be analyzed in one go. So you just send off one test. And the other big change is that all genetic tests on the genomic test directory are centrally funded by NHS England. I'll go on to that later. So I thought I'd try and so I'm going to talk about our transformation project and try and put it in the context of the wider things that are going on in the NHS with regards to genomic medicine. And I think there's a very strong belief and drive from the upper echelons of NHS England to use genomic advances, genomic medicine, to really improve outcomes across the NHS and to build in cost efficiencies. Now, whether this is realistic is a different debate, but this is certainly the aim and aspiration of the NHS. And to that end, clinical genetic services were reorganized in 2018 So previously there were 24 regional clinical genetic services. These were amalgamated into seven areas with genomic hub laboratories that are responsible for providing all the tests on the genomic registry, and these affiliated bodies, these genomic medicine service alliances. So I'll now go on and talk about what the service alliances were set up for. And basically they were set up to facilitate and support mainstreaming of genetic testing. And mainstreaming means that each sort of speciality area of medicine takes responsibility for its own diagnostic testing as listed on the test registry. And while clinical genomic services still retain all the predictive testing, so that's their sort of specialist area of work. And so they realized that there needs to be a lot of training and education of the broader NHS workforce to be able to implement this mainstreaming. And one of the kind of mechanisms to promote the mainstreaming are these transformation projects. And so that leads me into our local North Thames transformation project. So our area is North Thames, and they have national and local transformation projects. And actually our transformation project is covering two areas. One is genomic testing in intellectual disability services and also in dementia services. And I have to confess, the ID side are racing ahead, and they've done much more work than I have. So I'll just introduce the team, because hopefully they'll get an opportunity to talk about their work at some point. So Nicole, Edie, Sanjay, Nelson, and Ali and Asma. And it all sort of came about rather through serendipity, because I got put in touch with Dr. Faravelli at the North Thames GMSA, and she sort of explained to me what about mainstreaming. I in return explained what we do in dementia clinics and in intellectual disability services. And there was a realization that actually this is a big area where some transformation needed to take place. So the North Thames genomic medicine service covers, their footprint covers about 10 mental health trusts. And what we did to begin with, we went to the data held at GOSH about the request and tried to work out how many tests were coming from mental health trusts. And in an 18-month period, we couldn't find any requests that had originated from mental health trusts. Now, this may be actually a problem with data rather than that no tests were ordered, because actually in our own trust we have ordered a few, as I'll go on to say. But I think the reality is that testing numbers are very low, and I'm going to go on in the next few weeks to send out a survey to try and find out, put a bit more detail on that, and find out what people's experiences of thinking about testing and ordering testing has been. So the sort of the central component of these transformation projects is to come up with a generic test pathway. And so all the different medical specialities are being encouraged to develop these pathways. And there's an initiative that's sort of hosted by Health Education England, and all the pathways are going to be put on one website, so people can use that as a resource when they're thinking about, one, setting up their services, and two, when they're actually doing the testing and need information and details about how to practically do the testing. So we've got a draft one for intellectual disability psychiatry. I'm lagging behind on the dementia pathway. But one of the key components of this is how you relate to your clinical genomic services. And so we've been reaching out, and we've been connecting with the genomic service at Great Ormond Street and seeing how we could both best work together. And so one of the things that many specialities have is a separate virtual MDT with the genomic medicine service. I don't think we're going to have the volume of tests to necessitate that, but we can present at their general MDT and also their neurology MDT. And also once we've got a draft pathway approved, we need to send it out to consultation, for instance, to the Dementia Alliance. So as I alluded to before, that there's the workforce knowledge, training and expertise is a key to these transformation projects. And so I'm really pleased that within the last day, I suppose, confirmed that we've got a clinical nurse specialist to champion genomics within the trust. It's focusing on memory services. And the idea is that you train up, so that the genomic medicine service trains up someone within the trust who can facilitate testing across the trust and also work on educating people in the relevant areas. And specifically for this pathway, we're going to develop some bespoke resources which will hopefully help with the testing process. And there's also another resource provided by Health Education in England that gives some clinical vignettes which can be helpful. And we've got a draft couple of cases for those. So that's what's going on. The tests are there, they're on the registry, the criteria are set out, and anyone that meets the criteria is entitled to have that test. But sort of dialing it back a bit, why might we offer the test? Well, I mean, firstly, I mean, my experience hasn't been raising the issue of genetics very often. It's usually people come into the clinic, they know that it's running in their family, and they are proactively asking about testing. And so there's that drive to, provide the tests that are wanted. As Charlie alluded to, that the kind of gold standard for diagnosis, for definite diagnosis of dementia, is a genetic test in vivo. That is the only definitive diagnosis in vivo that we can make at the moment. And so if you've got the ability to make a definitive diagnosis, it seems churlish not to use it. There is also the potential for more rapid diagnosis. Charlie mentioned that, on average, it's about 3 years from first symptoms to diagnosis. In young onset dementia, where there's a sort of higher concentration of genetic forms of dementia, that delay is even longer. At the moment, we haven't really been incorporating genomic testing early on in the pathway, but there is that potential to speed up diagnosis. And of course, a genetic diagnosis provides information about recurrence risk for the rest of the family. And as I said, predictive testing is totally in the sphere of the clinical genomics test service, but they won't be able to provide any counselling usually unless the proband or the person has a confirmed genetic diagnosis. It all kind of rests on that. And then again, as Charlie mentioned, there's a rapid progress in the likelihood of disease-modifying treatments coming through, and a number of trials are being set up based on people's genotype. So the genetic testing will be an entry requirement for the clinical trials, and so this is going on in frontotemporal dementia, but also in familial Alzheimer's disease. So do we need it in mental health or memory clinics? Well, as people in the audience, I don't need to sort of convert the audience, the large majority of dementia diagnosis is done within mental health services, not exclusively, but the large majority. And that includes about 80% of diagnosis of young onset dementia. And when this has been looked at, the diagnostic yield of this dementia panel doesn't vary between a sort of bog standard mental health run memory clinic and a tertiary cognitive neurology centre. So I thought I'd just very briefly sort of mention our early experience of using the dementia panel within the Tower Hamlets Memory Clinic. And so last year, roughly seven requests were sent. And last year's a little bit odd because it was only in August that psychiatry was added to the list of people who could request the dementia panel. But I think two things, just sort of, won't go through the details, but two things come out of it. One is that the genomic testing actually altered the diagnosis. So the subtype diagnosis based on the clinical assessment was incorrect and was righted by the genetic diagnosis. And that actually explained the sort of progress of these particular people and their presentation. And the other thing I was just going to mention is that, as you can see, the first person was sort of white European origin, but these are variants that are seen in other people from other sort of ancestries. There seems to be quite a mystique around genetic testing. In many ways, it's not hugely different from any other test you might want to order. You fill out a request form, the bloods go off to the laboratory, and then you get a test result back, you get a report back. That's not to say that there are not some complexities and subtleties when you are engaged in genetic testing. So there are obviously issues around identifying the right people to offer testing to, giving information about the testing, explaining what the test can and cannot show, interpreting the results, and then translating those results to people in the clinic. However, I think in many respects, in psychiatry and mental health, we're quite well equipped and quite skilled to do much of that, because a lot of it is around capacity and consent. I suppose I should have really put this slide at the very start of the talk, because the R50 dementia panel is not going to transform the assessment and diagnosis of dementia. For the vast majority of people presenting with dementia, that it will not be appropriate to offer them genetic testing, at least not at the moment. We'd expect to get positive genetic results in about 1% of people presenting with Alzheimer's disease and about 20% of people presenting with frontotemporal dementia. So with a very rough guesstimate, I think we probably should be offering about one test per week across the trust. And of course, the test results may not influence management. In the couple of examples I gave you there, the diagnosis was changed, the subtype diagnosis was changed, and that does change the management in terms of which medication, etc., you could offer. However, if you're simply confirming, say, an Alzheimer's diagnosis, it may not particularly change the management. And also, while we can do a much more comprehensive and extensive screen of dementia-related genes now, we don't know all the variants in the genome that are causative of dementia, so it doesn't completely exclude a genetic cause. There can be results which are very hard to interpret, so a variant of unknown significance, and there are variants that are in associated genes, but there's not enough evidence to say that they're causative of dementia. And so you can only say that we've found the variant, but we don't know whether that's causing the dementia. And the family won't be able to get specific counselling on the basis of that, because the clinical genetic services will not do predictive testing on basis of a variant of unknown significance. And at the moment, it actually takes quite a long time to get the results back, because there's been an upsurge in testing. So just wanted to highlight that actually the Genomic Medicine Service Alliances and Health Education England has actually produced a lot of very good information to support and facilitate people testing in mainstream services. So there's a lot of stuff on the web already. If this is relevant to your clinical practice, I would highly recommend their workshops provided, organised by one of the principal genetic accounts at GOS. Jan and I actually joined one of these workshops last month. It was very good and went through the whole sort of testing pathway. And of course, you're welcome to contact me or Jan if you've got particular questions. So like Charlie, I've got some sort of shameless promotion as well. So we will be obviously disseminating and promoting the pathway once it's approved by HEE. Maybe I'll get asked a fourth time to give this talk. And also just wanted to mention that sometime this year, we hope that the college report on genomics in mental health will be released. It's being revised at the moment. It doesn't just talk about dementia genetics, but genetics more broadly in psychiatry. And as I said, I'm falling behind on my sort of bit of the transformation project. So if there's any SPRs out there who want to do a day, their special interest day in genomics, please get in touch with me. In fact, if there's anyone out there that wants to do it, please get in touch with me. And also, again, a sort of second shout out for the ID project, which is looking at a similar thing in their services. Thank you.
Lovely. Thanks, Nick. And I'm sure Nick will be available over tea later, won't you? If you'd like to form an orderly queue for the Genetics Special Interest Day, which sounds very interesting. So the next part of this talk is about treatment. And my research program is all about the non-drug approaches to dementia. And I've picked 3 areas of the research that I do with my team, a few of whom are here today and are going to contribute to this talk, to pull out, which I think are interesting and relevant to the current direction of travel, really, with regards to dementia policy. And the first one is earlier treatment. So you've heard the vision that we all share, that in future, diagnoses of dementia will be more accurate, far more akin to breast cancer. There'll be better information about genetics. And of course, all that will be in readiness for disease-modifying treatments, which we hope may well be approved in 2024. However, this graph is more where we are at the moment. So I guess many of us, our clinical experience of mild cognitive impairment or subjective cognitive decline is much more that generalized involutional change, MMSE of 27, that we have all heard about. And a few points which I would like to make here from this data, which actually comes from the larger NIHR Apple Tree program, which is a large program that I'm leading, concerned with pragmatic dementia prevention, really. Dementia prevention 15 years ago was something that people probably thought couldn't really happen. And there's been a huge sea change in how this is perceived. And there have been some wonderful proof of concept trials which have shown that if you do an enormous amount of intervention with people, you give them 300 hours of expert time, dietary advice, loads of exercise down the gym, huge amounts of support, that you can delay the onset and decline of cognition. So the question that Apple Tree has been asking is how much of that is actually translatable to something that's useful in the messier world of clinical practice. So at the moment, lots of people are recorded in their GP notes. This data is based on 6% of the UK population from the thin database that we looked at. Lots of people are recorded as having memory concern, cognitive decline, who don't have a dementia diagnosis. And this is what happens to them. Over 3 years, around about half of them get dementia. Now, this isn't even the population that get referred to our memory clinics, who are probably the ones that people are more concerned about. There's also socioeconomic biases in who gets to a memory service. But generally, even just going to your GP and saying, I'm a bit worried about my memory, means that probably in the next 3 years, it's almost 50-50 that you're going to get dementia. And predictably, if you're a woman or you live in a more deprived area, that's even more likely, which of course shows that you're that bit less likely to actually get that recorded in your GP notes. So my first point is, why wait? Why make the plan that we'll just see people every year and wait till they get dementia and then intervene? We know that half of these people are going to get dementia in 3 years. It'll be more in 5 years. And we know that lots of the things that we can do to reduce the risk of dementia are things like healthy diet, exercise, positive social engagement. They're not harmful interventions. They're not drugs with side effects. So surely we should be intervening now. And you've heard from Charlie about this feeling that people have of being in limbo when they have a diagnosis of mild cognitive impairment. And that's exactly what we found. That at the moment, there's wide variety across the country, but the chances are, if you go to a memory service and you get diagnosed with mild cognitive impairment, there will be a message along the lines of, here's a leaflet, come back if it gets worse, which leaves people often thinking, well, I came to you because I thought it was bad. What's worse? So on the basis of that, we co-produced the apple tree intervention, which is really intended to be a pragmatic dose of what the more proof of concept trials such as Finger have done in Finland. So if you, we've been enrolling people in our randomized controlled trial who have mild cognitive impairment or cognitive decline. Basically anyone that says that they've got to worry about their memory and they think the chances are that it's got worse over the last 5 years, that it's persistently bad. That's our broad screen. We don't ask for biomarkers. We don't do lots of complicated tests, which might mean that we get an over-rarefied sample. We pretty much take most comers who've got worries about their memory. And then half get the intervention and half get the usual care, which is, to be honest, no care for your mild cognitive impairment. And the intervention is done on Zoom, and people get together in groups of 5 to 7 every couple of weeks with 2 facilitators who are trained, but they're not clinicians, some of whom is here today. Thank you for coming. And they go through manuals and have sort of fun interactive discussions all about all the ways, the best evidence for how diet and exercise can help to maintain your cognition. The word dementia isn't in the manual at any point, and that was from our co-production. It's very unclear. Half these people wouldn't get dementia anyway, so this is far more positioned really as a cognitive well-being intervention. So as well as the groups every 2 weeks, in between, there's a more informal catch-up on Zoom where people chat, they make friends, sometimes they go out for curries, they go bowling, sometimes they meet because they've got on online. They get a non-perishable food delivery at the beginning, they get a pedometer, and they have access to our website, which most of them don't use, to be honest. Only 3% access to our brain training and all of that is online, which is interesting because often that is put forward as quite a good public health intervention. We found that people are quite reluctant to, most of these people have never used Zoom before. And so an important part of our intervention is having facilitators that can help people to access the video call. But once they do, we found that the adherence is really, really good. We did it that way, obviously, you probably guessed, because of the pandemic, but really with the support, it's been phenomenal, and it's been lovely that people have then, over the pandemic, they were able to Zoom families because we taught them how to use Zoom and so forth. And actually 85% of our sessions have been attended. So for those that managed to have that help to get online the first time, then it's a really good way of maintaining attendance. So embedded within the Apple Tree study, PhD student Christine Carter, who's here today, did an ethnography study, actually spending some time listening to the groups and seeing what actually goes on in those groups. We talk about dementia prevention, but what's actually happening? How are people engaging with it? So I think Christine's just going to come up and give you a few insights about that, aren't you? That's just a page from our Apple Tree manual.
Okay, thank you, Claudia. Yeah, hi. So I'm coming to the end of my PhD. I'm currently sort of writing up and pulling together the findings. And as part of the PhD, and I should say, oh, sorry, can you hear me? I should say my background is a mental health nurse working with older people with dementia and mild cognitive impairment in primary care liaison and psychiatry in sort of community psychiatry settings. So I was really interested in people who had dementia and people who didn't, but had concerns about memory. And what I've done as part of my PhD is focus on apple tree as an active aging intervention. And I've looked at it through an ethnographic lens, which means I've looked at it in an observational way, and that involves participant observation and me following up some of the people through with interviews. My actual PhD title is around looking at active aging policy and active aging practice, and thinking about how that can reconfigure what we know about cognitive impairment and what people think about that. So apple tree as an intervention, as an active aging practice, has been really useful to look at observationally and be part of. So what I did was I was part of the pilot study, and I followed 2 20-week programs through. Obviously I wasn't participating, but I was observing. I had a sort of role as a supporter, supporting the facilitator. So I had a legitimate role. Of course, as Claudia said, it was online because of COVID-19, which wasn't expecting as part of my PhD. So it's been quite an interesting insight doing ethnography online with people with memory concerns. And I'm just briefly going to tell you some of the things that I found. So I'm looking at that, and I'm drawing upon psychology and sociology to think about how people situate themselves in an active aging intervention, how they adapt it, and how they adopt it in their lives. Because there's a lot of rhetoric about active aging policy, and there's a lot of rhetoric about practice. And we know about mild cognitive impairment and the prodromal stage and dementia. But as we've said, it's very much an in-between experience. And I've looked at that in terms of, liminality and where people sit. And actually what I found looking at the intervention is people do feel very unclear, and they have a very unclear trajectory. And often the subjective experience of mild cognitive impairment is forgotten. And the intervention allowed people to take part in a number of activities through the content, which often ranged, well, the very, very popular ones were things around diet and nutrition and exercise. And it was something tangible for people to hold on to and to measure and to use in their lives to gain some clarity and structure. And they're also able to sort of navigate their way through a journey. So this isn't a static space, it's one of movement. And as Claudia said, some people will develop dementia, but lots of people won't in that intervention. So it's thinking about what that trajectory is and how we support them. And I think the other thing is the intervention allowed a space for people to share their concerns in a shared communal space where there's a commonality with other people the same age who had memory concerns, and people would share compensatory strategies that they'd used. They would adopt some of the activities. They would also be able to retain their identity, which may well be compromised through having a cognitive impairment or concern. And that was really important. And they would do that classically through being able to become active agers in the intervention. So there was an obligation, and there was a hope, and there was an expectation of why they were taking part. And also, actually, interestingly, through Zoom as a platform, they were able to use the background setting and engage with the intervention very interactively. So what happened was they would send pictures in of recipes and food, and they would get things from the background and be able to show and share things with the group in a way that they probably wouldn't be able to do in a face-to-face group. So actually, this assumption that they weren't, people with mild cognitive impairment wouldn't be able to take part on Zoom was challenged, and it challenged me as a researcher. Because a lot of people, as Claudia said, had not used Zoom before, and they were supported by some of the facilitators. And in fact, they embraced it. And many of them found it was a new skill, and it gave them some confidence. So that was some of the insights from my work. Thank you.
Thank you, Christine. I think it's nice to hear from people that were actually there, don't you? Because we often think about these interventions in a box. And Christine was in the box, so it's nice to hear what actually happened. And actually a lovely thing that happened in the apple tree study was that there was lots of sharing of photographs, and because it's hard to remember now those days in the depths of the pandemic, but people would say, I went for a walk, look at these pictures I took on my walk. And we were given the opportunity to bid for a little bit more money. And our co-production panel really came up with the suggestions together that we should have a photography exhibition. And we did. We had an exhibition in the welcome, and it was on, was it the 8th of September? It was on the day that the Queen died. And Daisy Cooper MP was meant to come and open it for us, and she wasn't allowed out of the House of Commons. So she said, come to us. So there we are at the House of Commons with, and this is one of our participants showing the photographs to Daisy Cooper MP, who's the health spokesman for the Liberal Democrats. So that was very interesting and lovely to work with participants in a different way. It really did feel like true co-production. So the next dip into our work that I propose is to think a little bit about how we can personalize non-drug treatment. So you've heard about how we can personalize the drug treatment, but actually the approach where somebody comes to a memory service and you just tell them everything, you go down a long list and say, you could do this, you could go to the carer center, you could do that, is something that we're trying to move away from, to much more asking people, what do you want? What do you need now? Because the evidence suggests really that that is, people can only take in so much at this time in their lives. And so you need to give them what they need. And to enable that, Jessica is now going to come and tell you about the NIDAS program, which Jessica has been program manager for through the Alzheimer's Society, where we've been developing a system of manualized personalized care to really try and roll out this approach and make it available to many people.
Thank you. So yeah, I work as the program manager on NIDAS, and NIDAS Family was co-produced in a lot of co-production workshops with people living with dementia, family carers, clinicians, and then it was piloted, and now we're doing our main trial. And the NIDAS Family intervention is a psychosocial intervention that's manualized but very personalized, because it's all based on people setting their own individualized goals at the beginning. So, so the co-production group identified all the areas that were important to people who are living with dementia at home. And then we created the modules that we hope address those issues. And our primary outcome is goal attainment scaling, which is quite a new outcome measure being used in dementia trials, you know, that captures really individualized outcomes by people individualized, sort of setting their own goals that, and then in a scalable way. And then those goals are used to map their own choices, their modules. And then they have a final session to put it all together. And then we also follow up for up to a year with follow-up phone calls. And so this just shows the different modules. And the most popular module is managing mood and identifying enjoyable activities, followed by carer wellbeing and support. So we've recruited 302 participant dyads, people living with dementia and carers, and we will get the trial results in May of this year. So we'll be able to share the results then.
Thanks very much, Jessica. Yeah, so we shall see, and Jessica's going to be presenting the results in Amsterdam at the AAIC, so might see lots of you there. So this is just bringing together the work that it's been a 6-year program now, actually, the Centre of Excellence for the Alzheimer's Society, which I started in UCL and is now based in Queen Mary. And Jessica's told you about the NIDAS Family tailored intervention of 6 to 8 sessions delivered over 6 months to family carers and people living with dementia. And 85% of those offered the intervention completed it entirely. 3% died and only 12% withdrew, which is very low compared to other trials. And we think that that's partly the flexibility of delivery, which could be on Zoom or on the phone, and partly the nature of it, that it is tailored. And you're probably less likely to drop out of something if somebody said, what would you like to do in the next session? And you've had choice over that. An add-on study that we're doing called NIDAS Professional is to try and look at how we can bring some of this help into social care. because there has been a lot of concern recently that social care has a lot less thought in terms of research evidence in implementing interventions compared to the health sector. So we've recruited 6 home care agencies and randomized them, and those receiving the intervention, all of the clients and family carers who are eligible have been offered NIDAS family, and all of the home care staff have been offered a 6-session complementary training program. And we've learned a lot from that. As a feasibility trial, we set endpoints at which we say if we achieve this, we will go for a full trial, and we did achieve them, but it's not been uncomplicated. So 68% of the home care workers completed the intervention, which is lower than for the dyad, and I think reflects the complexities in social care at the moment. And that range varied enormously from 18% in one agency to 88% in another. And I think that shows that it's rather than individual home care workers, it's more about the systems and the management. Just over half of the eligible dyads received the intervention. So just a few quotes, which I'll leave you to read. Obviously, we haven't got our formal results of how our trials have worked in terms of whether people have met their goals and so forth. But people often email us with quotes. My favorite one is this one from a family carer who said that NIDAS family, it gave us 2 more Christmases. That actually the strategies that she was helped to adopt kept her mother at home for 2 more Christmases. So although she eventually did go into a home, that carer felt it was later than it would have been, which is what we seek to achieve. So I'm going to hand over finally to Dr. Moïse Roach, who, as with the other 2 speakers, has just arrived at Queen Mary. And he's going to tell us just one slide on his PhD work, looking at how we can deliver more equitable care.
Thank you, Claudia. Yes, it's actually warmer here. It's freezing down this corner. So yes, just a very brief about my PhD, which was looking at how Black African and Caribbean deal with dementia, how they understand dementia, how they manage it as well. Now, I'm sort of, okay. So I thought I'll probably just focus onto a key theme that came out. So just to tell you that the study was actually qualitative. So what I spent my time doing was interviewing people, but also observing some. And one key point that came out about care, so I'm going to concentrate on that because that's what we're talking about. It was sort of acknowledging the differences between ethnicity. Now, participants did ask that. They did ask to recognize that they perhaps pay more attention to the family role within looking after someone with dementia, particularly because some of them, or many, are migrants, and they also feel that they may not belong, and they don't feel the need or that desire to sort of put their sort of relative into a condition that might bring a little bit more difficulties because they felt that they were not belonging in their areas. They also had questions about the quality of services. Now, there's a lot of question about, lots of information saying to encourage minority ethnic population to come into services, report their dementia. We usually encourage people to do so, but one of the issues that seemed to come out a lot was that people think, oh, well, when we're there, what do you have to offer to us? Because they felt that services were not appropriate to their needs. Now, this is why we obviously need to make sure that we sort of provide services that will respond to the need. We actually recognize the needs, but also acknowledge them. But as you may see in that last quote, the one at the bottom, one of the family carers mentioning it's good to recognize those differences, but we need to make sure that it's not always focusing on race and ethnicity. She was worried that the moment that we see someone who is a different ethnic group, we tend to racialize them. So she was sort of saying that we need people who are able to recognize to distinguish between this is about race or ethnicity or culture, and this is simply about perhaps another need. I won't tell you more, I hope I will have the time to tell you a little bit more about my PhD, which was over 3 to 4 years. And also, I also intend to develop this into a postdoc. So I would definitely like to talk to more people about it and how to sort of develop that in a little bit.
Thanks, Roy. Okay, so thank you to my fellow speakers. Because I have shamefully run over time where the other speakers did not, we're going to take our questions over tea. And I'm going to hand straight over to Afia, who is going to talk to you about the context of dementia in learning disabilities.
Thank you, Claudia. So I'm Afia Ali. I'm a consultant psychiatrist for people with learning disability based in Bedford, and also an honorary senior lecturer at Queen Mary's. And the focus of my talk will be on psychosocial interventions for people with learning disability and dementia. Okay, so I'm going to make reference to a systematic review that one of my MC students recently completed and has been submitted for publication. And I'll briefly talk about some of the research that I've been involved in as well, and that's ongoing. Okay, so why is it important to study dementia in people with learning disability? So we know that people with learning disability have an increased risk of developing dementia, and they're also more likely to have an early onset of dementia. And partly that's linked to the cognitive reserve hypothesis, which postulates that having a high IQ and more educational attainment and occupational attainment makes you more resilient to brain insults that might make you more susceptible to dementia. And of course, people with learning disability have low IQ, and so that makes them more, potentially more vulnerable to dementia. But also, people with Down syndrome have a significantly elevated risk of Alzheimer's dementia, which is related to the fact that they have, usually have they do have an extra chromosome 21, and then there's that results in an extra copy of the amyloid precursor protein, which increases the risk of Alzheimer's dementia. And if you follow people with Down syndrome up over a period of time, the majority, so over 90%, will develop Alzheimer's dementia in their lifetime. So given the high prevalence of dementia in people with learning disability, we need to have interventions available in order to improve outcomes in people with learning disability. And so what are psychosocial interventions? So that's the focus of my talk. So these are non-drug interventions that aim to improve symptoms, aim to improve emotional and psychological well-being and overall quality of life. And we know that there is increasing evidence in the general population that psychosocial interventions, particularly cognitive stimulation therapy, improves cognition and quality of life. But there's also increasing evidence for other types of interventions, such as cognitive rehabilitation therapy, occupational therapy, and also reminiscence therapy. However, the evidence in people with learning disability is very limited. So the aim of the review was to examine the evidence for the effectiveness of psychosocial interventions in people with learning disability, but also to look at specific adaptations that have been made to the interventions to make them more suitable for use in this population. Okay, so we searched 5 electronic databases. We looked at grey literature, and the search was done between March and May last year. And studies were included if they had participants with learning disability and dementia of any severity and any duration, and they evaluated psychosocial intervention in any setting. And we're particularly interested in outcomes related to cognition, behavior, psychiatric symptoms, adaptive functioning, and quality of life. And we had 2 reviewers screening the studies and extracting the data, and studies were assessed for quality as well. So this is the flow diagram. We started off with about 2,000 studies, and then we whittled them down to 10 studies that we thought were relevant for inclusion. So out of the 10 studies, only 4 were quantitative, and of those, only 1 was a randomized controlled trial. 4 were qualitative studies, and we had 2 studies employing a mixed design. Of these 10 studies, 3 were high quality, 3 were rated as medium quality, 1 was low quality, and there were 3 studies that couldn't be classified. And so for the purposes of the review, what we did was we categorized the interventions into 3 broad groups. So we had one group, one category that looked at behavioral interventions. So these were interventions that targeted particular behaviors related to dementia. We also had another category for structured interventions. So these were manualized interventions that were delivered in a standardized way. And then the third category were personalized interventions that were based on sort of goals and personalizing the intervention and having a sort of flexible way of delivering them. So I'm going to start off with the structured manualized interventions. So we've got 5 studies that were categorized in this group. And I'm just going to briefly talk about each of these studies so you get a sense of what kind of evidence is out there. So the first study is of the memory cafe, and it was a pilot study, a single arm study that looked at outcomes before and after. And this particular study looked at a memory cafe, and it uses principles of cognitive stimulation therapy, which is an intervention for people with mild to moderate dementia, which aims to improve cognitive functioning by engaging people in activities that stimulate the brain. So what they did was they had 12 weekly sessions where participants participated in physical, cognitive, and creative group activities. And it was facilitated by staff from the community learning disability team. And the groups were attended by 5 to 11 participants. The main outcome of interest was looking at changes in affect scores. So the way they assessed this was that they had an observational rating scale, and they looked to see if the participants appeared happy and were in a good mood during these sessions. So they found that at the end of towards the end of the intervention, so the 7 to 12 weeks, they found that affect scores were better compared to the first 1 to 6 weeks. They also obtained feedback from carers who reported that there were improvements in communication, alertness, and general level of participation. And then in terms of adaptations, they simplified some of the activities to make them more suitable for people with learning disability. They also had a higher ratio of staff to attendees in order to improve the amount of support that they could provide, and they used inclusive communication strategies. And also the carers received psychoeducation throughout the program as well. And they each week they had a talk about dementia that was specifically related to people with learning disability. The second study I want to mention is a feasibility randomized controlled trial of individual cognitive stimulation therapy, which is a study that I ran a couple of years ago. So in this study, we had 40 participants with mild to moderate dementia and learning disability, and they were randomized to either receive individual cognitive stimulation therapy or treatment as usual. And the carers delivered the intervention, they were trained, and they were asked to deliver 2 sessions a week over 20 weeks, so 40 sessions in total. We looked at a range of different outcomes in the individual and also carers, but I guess the main sort of take-home message was that there was an improvement in proxy rated quality of life in the group receiving the intervention at 21 weeks compared to the treatment as usual group. And the effect size was large, but obviously we have to, given the small sample size, we have to be cautious about interpreting the results. There were no other differences in the other outcome measures. In terms of adaptations, we took the original manual that had been developed in the general population, and we worked with a speech and language therapist to simplify the activities. We also carried out some stakeholder consultation groups with professionals, with service users, and with carers in order to get feedback on the activities. And we also piloted the activities before doing the main trial. All right, so the third study I wanted to mention was a study on reminiscence therapy. So reminiscence therapy is about encouraging the person to recall pleasant memories from the past, and often it involves looking at photographs and objects. I guess the sort of main advantage of reminiscence therapy is that a person with dementia can, because obviously they have difficulties recalling recent events, that they find it much more easier to speak about past events. So So it helps to sort of promote communication, but also it helps to promote well-being. So in this study, this was a study of 5 participants using a single case design series. And what they did was they looked at a personalized life story book, as well as a rummage book. And participants were randomized to 3 conditions. So either receiving the life story book, the participants all received the 3 conditions, but at different times randomly. So either the life story book, the rummage box, and no intervention. And what they found was that when the participants were looking at the life story book and were looking at the rummage book, they seemed to be happier. And again, the sort of well-being was rated using an observer-rated tool. Okay, this study looked at improvements to the environment, but also looking at how improvements to staff interactions can also potentially improve outcomes. And they used something called an action research cycle. But essentially they found that, that during this sort of process where they did observations of staff and the environment, they then gave feedback. This led to some goals being set, and then they repeated the cycle about 4 times to see if there were changes over time. And they found that over time, there were some improvements in that participants had more sort of enriching experiences compared to baseline. And in terms of adaptations, they didn't really sort of talk much about the adaptations, but essentially the carers were encouraged to deliver the interventions in a flexible manner. Okay, and another study looked at special care unit for people with learning disability and dementia and compared outcomes with a day centre and nursing home. And this was a study of 14 participants who were admitted to a special care unit, and staff in the special care unit received psychoeducation. There were also some environmental adaptations that were made to the special care unit, and also the participants had access to individual and group therapies. And they found that for people with Down syndrome in particular, they had better outcomes if they were in the group receiving the special care unit. But over a 3-year period, the residents in the special care unit had better daily functioning compared to those in the day centre and the nursing home. So that was a sort of quick roundup of sort of evidence for structured interventions. But what about personalised interventions? And there are sort of 3 main studies really that I'm just going to briefly talk about. So the first study is of goal setting and impact of goal setting on improving behaviour and quality of life. So this was a study using cognitive rehabilitation therapy techniques. So that sort of attempts to teach individuals strategies to compensate for their cognitive deficits that might impact on their daily functioning. So this was a single-arm study of 16 participants. The participants set goals themselves, largely focusing on improving mood, reducing anxiety, and engaging in more activities. And they chose the interventions themselves. And at the end of the intervention, over 70% of individual goals were met or exceeded, and there were some positive reports from staff as well. But there were no significant changes in individual measures of symptom severity or quality of life. Another study was a case study of 4 individuals who received personalized technology to promote independence. And essentially, the study found that actually by introducing technological adaptations, it did lead to improvements in independence for these individuals. And then there was one case study of one person with dementia and their carer. And this study looked at how making carers more, teaching carers to become more sensitive and more responsive to the needs of the person with learning disabilities could potentially improve outcomes. And they showed that actually at the end of the intervention, the individual appeared more motivated and was able to learn strategies and adapt to the environment, but there were no improvements in memory. And then finally, behavioural intervention. So these interventions mainly targeted specific problem behaviours, and both of these studies used reinforcement as their main way of trying to modify behaviour. And essentially there were case studies of two individual people, and they found that using reinforcement did lead to improvements in behavior. So just really summarize the findings of the systematic review. So essentially we found that there was emerging but very limited evidence for the effectiveness of psychosocial interventions for people with learning disability and dementia. And most of the studies were very small sample sizes. They didn't have control groups. There was only one study that used a randomized control trial design. So really, I think it points to the need for more high quality studies using robust designs, but also it highlights some of the difficulties that we do have in carrying out research in people with learning disability and dementia. In particular, one of the challenges that we find is that the diagnosis of dementia can be quite complex in people with learning disability, and often people are diagnosed quite late. They may not receive diagnosis at all, and by the time they do receive a diagnosis, they're often not suitable for interventions that look at that use psychosocial interventions. So that's one of the things that we, as researchers, we have to kind of bear in mind, how we can try and improve access to diagnosis and improve that diagnostic process. And just finally, before we go and have our tea break, this is just a research project that I'm leading at the moment, jointly with Amy Spector from UCL. And it's a feasibility randomized control trial of group cognitive stimulation therapy compared to usual care. And we're aiming to recruit 50 participants across North London and also the northwest of England. And it's a feasibility study. Primarily, we're looking to see whether we can recruit enough participants to take part, and also whether people are able to attend groups and are able to, whether the groups are delivered as intended. If we're successful, then I guess the next stage will be to apply for funding for a larger RCT. But as I mentioned, recruitment and actually finding people to take part in these studies is quite challenging. So hopefully I'll be able to report on the results of the study soon. So thank you very much.